Good afternoon, everyone, and welcome to the National Center for Health and Public Housing's webinar on best practices on identifying additional sources of funding for outreach activities for residents in public housing. Welcome, everyone. I'd like to take a few moments to introduce our guest speakers this afternoon. First, we have Henry Taylor, who's the Chief Executive Officer of Miles Square Health Center in Chicago, Illinois. Welcome, Henry.
Well, thank you. Thank you.
And then we also have Bill Phelps, who's the Chief of Programs with Clinica Vista in Bakersfield, California. And along with Bill this afternoon, we have Juan Garcia, who's the Director of HIV/AIDS Services with Clinica Vista. Welcome, Bill and Juan.
Thank you very much.
Thank you.
So I think as we begin here today, I wonder if we could take a few moments for each of you to tell us a little bit more about your health center, maybe a little bit about the history of your health center, what the annual budget is, how many staff you have, so just sort of the basic ground setting. Henry, would you mind going first?
Certainly, I'll be pleased to. Miles Square Health Center, University of Illinois Miles Square Health Center is one of the oldest community health centers in the United States. Founded in 1967, so we are approaching 50 years of age. We are part of the University of Illinois proper. We are a public sector FQHC, which makes us a little different than most 501c3s that are incorporated. Founded on the west side of Chicago, and in fact was founded because of its ability to serve a very dense public housing population that was housed on the Chicago west side. Our annual budget is a little bit over $25 million, and we have about 200 staff members. I'm using round numbers until I can get the accurate count.
Wonderful, wonderful. Bill, would you share a little bit about Clinica Vista? And I also understand we have Margarita who joined us, and you might want to introduce Margarita as well.
Okay, Margarita is our healthcare for the homeless manager. She's been in that position now, I think, for over 3 years, and also prior to that worked in our HIV/AIDS program as a case manager. I'll just give a little bit of a background. Clinica Vista has been around now. We're in our 44th year, so we started in 1971, and we started out primarily as serving the farm worker population and outside of Bakersfield in a small community called Lamont, California. And then over the years, we've expanded into community health as well as healthcare for the homeless. We currently operate 29 health centers in Kern and Fresno counties and one small frontier clinic out in Inyo County near Death Valley. We have an annual budget of about $90 million and a staff of 1,100.
Oh, that's great.
You're huge.
Well,
we're one of the largest FQHCs in the United States, in the top 3 or 4, I believe, in terms of the number of patients and so forth.
Now, Bill, do you guys currently do work in public housing, or are you looking to do work in public housing, or a little bit of both?
Well, I mean, we work in public housing through our homeless population connections, but we aren't receiving any 330 funding through public health at this time. We do have a new access point, which is a clinic that would be in a public housing facility. And if we get that granted, I believe, I didn't write that grant, but we may have applied under public housing for that particular new access point.
Great, great. And so when you do your work in public housing right now with your Healthcare for the Homeless project, is it just basically one site, or are there several sites that you're working with?
Well, we're working primarily with the Housing Authority of Kern County. They have set aside quite a few Section 8 housing vouchers for the chronically homeless through the Housing First program. And we've obtained funding from HUD through our Continuum of Care, the COC, to house. Currently, we're not 40 vouchers a year to house the chronically homeless.
Wonderful, wonderful. Now, Henry, you guys, Miles Square is a public housing primary care grantee, correct?
Correct, yes.
Will you tell us more about your PHPC grant?
Surely. We have 13 sites scattered throughout Chicago and the surrounding suburbs. Currently, we serve about 1,200 public housing residents. Now, the 12 sites we have, but Chicago's a little different because it has gone through a major regentrification or reformatting of its public housing programs. Many of the areas that were once bastion of public housing, high-rises and towers, are now bastions of high and middle income individuals. So our public housing residents have been scattered throughout the Chicagoland area and also throughout its surrounding suburbs. We've expanded our sites and having integrated our primary care, our public housing into our overall primary care strategy. So our sites are proximate to where our residents are now housed and in communities that have high concentrations of public housing residents overall in the urban core in the city of Chicago. So we've seen a major transformation of public housing in the city of Chicago. So our strategy is a little different.
So has that, and maybe we can get a little bit more into this when we're talking about funding, but has that changed the type of services that residents are receiving or need?
Not really, because the one piece that it has done, has made more challenging, was to outreach is a little bit more of a challenge, you know. When you were able to go into a housing complex, you had, residents pretty well to your disposal. Now, because they're more scattered out, it's a little bit more challenging. We do have, areas of public housing in Chicago, but again, it's a lot more scattered than it has been in the past. There are a couple of things about the numbers, however, as you well know. All of us challenged with the data on public housing in terms of accuracy and collecting those. We have worked with our Chicago Housing Authority, and now we're running database so that we can run our patient demographics against their database so we can better track where they are. So we're able to look at two things. One, those patients that are truly identified as public housing, and then we have those that are voucher programs, which sometimes gets the debate about, with the feds, about do they actually qualify. But now we know that the feds are allowing us to sort of use those numbers. So we've done two things from our perspective to management perspective to keep intact with our public housing. One, a much closer relationship with CHA administration, so we can look at events, planning events together, but also running data so we can be more in tune to where our residents are going.
Great. Bill, have you guys experienced anything similar to that, or how is the landscape of public housing in Bakersfield?
Well, I think that we still are developing. Our housing authority is developing, projects or communities, but they're also doing more scattered site type development as well. But Bakersfield's nothing in comparison to the Chicago metropolitan area. Although we also our county though is the size of the state of Massachusetts, so we have about 75,000 people living in 8,000 square miles, with a concentration here in the Central Valley portion of the county. But we also have mountainous areas as well as desert areas in the eastern part. It takes about 3 hours to drive from one side of the county to the other. It's so large.
Wow.
But so we have this issue of how do we serve people in outlying areas. The Housing Authority does have projects in most of the towns in the county. There's always a waiting list. I'm not sure if we have that many patients we're serving that actually live in a public housing project. Most of the patients we're working with have the housing choice vouchers.
Okay.
We're working with renting apartments from landlords.
Okay.
versus dealing with the public housing, the actual facility that's owned and run by the housing authority.
Yeah, I think as time evolves, every city and county throughout the country is really implementing public housing in just such a very different model. So it's really great to hear a different perspective. So when you think about, and maybe Henry, you could sort of start with this question. When you think about, here we are at the end of June, and probably right now or within the last couple of weeks, you had to give your board of directors your proposed budget for the next fiscal year. And, as much as we want to balance our budget, there oftentimes are some areas that are a little questionable with funding, and we're not sure exactly how guaranteed that funding is. Can you give us just some indication? We're going to move into our fundraising part right now, or in our funding part. Can you give us some indication right now on how much you go into the fiscal year thinking, gosh, I may have to raise X amount of money, just a sort of ballpark?
Well, good question, Dave. We start our year with a balanced budget, balanced budget, surplus, try to budget a surplus as part of our budget process at Miles Square. So we don't go out with the strategy of having to raise that money going forward. That is a plus for us, and I'll get a little bit more in detail. So quite frankly, we have to create a balanced in our surplus budget by the end of our prior year and beginning of a new fiscal year. The fundraising, we don't do a lot in terms of fundraising. Our board of directors, to be very frank, we do a lot in terms of grant writing. We go through public foundations. We set a goal of, it depends on every year, sustaining $1 million+ worth of foundation-based grants to support programs and activities. The challenge has truthfully been able to lift our heads up to host an event. We talk about people throwing a gala. My board is talking about as set a charge out for us to do a gala perhaps in 2016. But our real focus is on development from the perspective of grant writing. The Chicago Community Trust, Robert Wood Johnson, looking at those entities to help support some of the programming we do here at Miles Square. Does that help you in a way?
Absolutely, absolutely. Bill, what about you all at Clinica Vista?
Very similar to what Henry was describing. We really do very little actual fundraising. We do get some donations, but it's primarily through grants, as well as our clinics are supported through third-party reimbursements. And so I'm not part of our corporate-wide budget process. I'm just aware of kind of what goes into it, the big pieces. But again, we start our fiscal year actually starts on April 1st.
Oh, okay.
And that is always presented to the board, usually, earlier in, probably the January or February meetings is when that budget is presented. And a lot of it, our biggest source of revenue is Medicaid. In California, it's Medi-Cal, but it's and then a little bit on private insurance, sliding fee scale, and then it's grants. We have our clinic cluster grants through our 330 funding sources, and then we have about $14 million in annual grant funding from about 50 to 60 different sources. From Ryan White to SAMHSA, HUD, our WIC program is funded through the state, but that's USDA funds. Foundation funds from the California endowments. We've had funds before from the California Wellness Foundation. We've also we have a couple respite programs. The one in Fresno is actually being supported by the Fresno area hospitals. They're supporting the both the facility at the Rescue Mission in Fresno, as well as the on-site medical and case management services that we're providing through an annual grant through the hospitals, and I'm sure that's part of their community benefits program. Outside of that, we haven't really been very successful in tapping into the hospital's resources. They've generally will provide those services directly themselves, or they give out very tiny grants. We've gotten some from Kaiser, although for a very odd reason we missed the last funding round. So we were getting about $25,000, $30,000 a year from Kaiser. That's about the biggest we get from like a local healthcare entity.
One other thing we're kind of tracking is the California waiver that they submitted to the federal government to be able to possibly bill for Medicaid services for housing or homeless services. The update, the federal waiver, which was a $17 billion request that has to be justified by the state to the federal government, but was submitted, I think, in late March, and we're hoping to hear back a response in October on the different elements that were submitted. And we're hoping that creates another avenue, another stream for housing, because right now, what we're getting from the Housing Authority is the discussion is that the supportive services that are needed to be connected with these housing choice vouchers is not available. So, a lot of the groundwork that would need to be done to place these individuals in housing is not available at this time. So we're hoping that this source, along with working together with ACA enrollment, can help fill a gap and utilize. I don't know how many vouchers they have, but they have quite a bit. But the problem is the casework around that. So we're hoping that create something new opportunity.
Thank you so much for bringing that up. I'm actually calling in from New York, and we're watching California very closely to see how this plays out, because there's talk that New York may go that way within the next couple of years. So I wish you guys lots of luck in that process. So when you back to sort of the funding part, and you're thinking about clinical and just sort of programmatic expansion to provide services to your residents, is there an area, or are there areas that you're looking to expand for those populations? Phil, do you want to maybe take a stab at that first?
Well, I know that particularly in the area of our healthcare for the homeless, we've been really seeking funds for behavioral health services, and as I had mentioned before the call officially started, we did obtain a SAMHSA grant that is working with chronically homeless individuals and linking them to housing, and we provide, it's on a voluntary basis, it's not a requirement, but we do provide a very in-depth substance use treatment program, as well as mental health services. And we actually had our first group of 4 graduate a few weeks ago. We're using the matrix model. It's an evidence-based model. And so that's an area, and so we want to sustain that. So one of the things we're going to be looking at is the ability to get drug Medicaid funding from the state. Actually, most of our recipients are either on Medi-Cal or Medicaid eligible. I'll try to keep it to the generic federal program. California renames everything. But we're really, to sustain this, a 3-year grant, so we really are, and sometimes SAMHSA grants are sometimes really challenging to continue or renew. They're very competitive, and they sometimes want you to shift your focus. But we really need to continue these types of services to really help house and keep this population housed. And it's part of that supportive services that Juan was talking about. There's a lot more vouchers than we have supportive services, and we can't keep people housed without these wraparound services.
Absolutely. So, Henry, when you think about your residents in Chicago and where you would like to, some program needs for your public housing residents, what do you see in the future for them?
Several things, David. One, I echo prior comments that a large emphasis on the behavioral health aspect. You know, with the state of Illinois, there's been a number of cuts to services that are provided through Medicaid by the state of Illinois. We have a number of social service agencies that have provided behavioral health support have closed. So it's incumbent upon us to step up, and as we try to provide more of an integrated approach to behavioral health in our primary care, our major part of our focus is to provide more integrated behavioral health in our practice in areas in which we can hand off more complex behavioral health issues to our hospital partners or to our academic partner across the street. So my first emphasis is on placing and growing our behavioral health piece. Another gap would be in terms of, in the state of Illinois, we are challenged with providing adult dental care. We provide dental care to our pediatric population, but the state has cut our adult dental care, so I'm left with the challenge of how do I sustain and provide adult dental care to our patient population, and don't have a solution for that right now given the enormous cost, but it's one that I'm charged with. The third one is one in which we're working in terms of remodeling our practice so that we are focused a lot on blending our patients so that we have more of a care coordination across our services and across our patient types. So we're looking at severity of illnesses. What are the things we need in terms of integrating our outreach workers with our care coordinators so we have a team that looks at our patients and can outreach to them and look at what their medical and social determinants are, needs are as we provide care for them. A fourth issue, and as I look into the future, we have school-based clinics, and was intrigued by a conversation I had yesterday with some potential funders about how do we look at the social determinants of not just health, but of school. You know, how do we integrate health and our and social determinants to help our kids become more successful in schools, just as we look at the barriers that are pervasive in getting access to health care and in working in improving health care. We are finding that we see the same kinds of issues in terms of our kids finding success models in schools, being able to graduate, being able to get good grades. So we're beginning to take a look at what we can do with CPS and with some funders to begin to address some of those issues that may well make it very difficult for our kids to have not only health in their school, but also good, healthy learning environment that extends beyond the classroom and into their homes. So it's just some interesting things to think about that we've been thinking about how to approach this in Chicago.
That's really great. That's really great. So when you, Henry, your grant writing activities, can you tell us more about what that actually looks like for you guys at FileSquare?
I wish I could say I have a team of grant writers. I have a grant writer who works with my office, and it's the senior team, senior leadership team in our grant writer who works on prioritizing the grants we are going after, strategic approach to how we look at grants. So that's an ongoing process, and there's something going on all the time. We also have what I should say is through the university, and I've charged through the university a development department. You know, I am able to tap into them, and I've charged them with trying to find funders, and they've been part of our arm and part of the resource we can draw upon as we look at foundation grants. You know, bringing the Chicago Community Trust, which they've done, helping us when we look at our telehealth program. So while I have a core team myself, I am able to pull on the foundation of the University of Illinois.
That's great. That's great. What do you guys do over at Clinica Vista, Bill?
Well, and it's very similar. We don't have, like, it would be wonderful to have a full-time grant writer. We do occasionally contract out for assistance, but most of us on the executive team and department directors and managers like Juan and Margarita, we're all seasoned grant writers.
Yeah.
And again, we look at how that fits in with our strategic plan. Again, we focus on those things that we really feel we need to expand into, like behavioral health and integrated behavioral health services, and especially for targeted populations like the homeless.
Mm-hmm.
So that's it's pretty similar, and we don't have we work with the local state university, but they don't really provide that kind of support for us since we're not directly part of that organization. We're standalone, but they can usually we get help from our health department, public health department, for epidemiology, epidemiological data. They've been really good for our Ryan White grant, helping us to get the data for that. So we have depended on outside sources to help us with. I think we had UC Davis helped us with a needs assessment for one of our New Access Point grants. So we do use outside sources sometimes, but the bulk of the writing is done by staff.
How did the UC Davis piece sort of develop? Can you tell us more about that?
The person who was involved in that, her name is Pritika Ram. She wrote most of our New Access Point grant. That was a connection that somehow she made. Our CEO has been in managing our health center for almost 42 years, and so the connections that he has goes very, very deep. And so it's probably through those connections that we were able to make that linkage. But we've also worked with UCLA. Our behavioral health department has worked with our county mental health program and UCLA to it's been going for several years now as our integrated behavioral health program at several of our health centers. And so UCLA has been doing the evaluation piece.
That's really great. I think academic partners really do provide wonderful opportunities.
They help
Henry, please, I'm sorry, Bill, I interrupted.
They really help to validate the work we do, and to when you're looking for funding, you have to have valid data and evaluation. So it's been very helpful to partner with the universities.
Great, thank you, Bill. Henry, just before we leave this topic, do your program staff also participate in the drafting of responding to grant proposals?
Yes, very much so.
Okay.
Very much so.
How about the board of directors? How involved does the board get in sort of grant development or grant relations or those sort of things? How about with you, Henry?
We always do, and actually always get approval, and we give them a briefing on the grants themselves. Every grant we go after, the board approves and gets a briefing on them. However, they have a far more active role on the development end as we look at work with founders or foundations. They meet with me with foundations when we have events here at the health center. They're present and and rubbing the flesh or schmoozing with public officials and funders. That's part of something we do ongoingly with our board.
Bill, how about at Clinica Vista? What do you guys, the board involvement?
Well, similar in terms of the board, is they're kept informed of the grants that we apply for and when we're successful in getting them, but they're not really involved in kind of. I would say more when we've had strategic planning sessions, when we've involved the board and senior management. We've been involved in more of kind of the big picture direction in terms of where we want to go. But in kind of the more detailed areas in the program side, like where Juan and Margarita are, and really where I am as well, they're not. I would have to say they're not really that involved, other than the informational part. We really work with our CEO to make sure we're on track with where he wants us to be heading, and he keeps the board informed then, of course, where we're going.
That's really great. Thank you. Thank you. So as we move over from funding a little bit to innovation, I'm interested in what type of innovation and innovative programs you all are working on or hope to work on. More specifically, I'm interested in what you're sort of proud of, that you thought, wow, I can't believe I was able to get this thing funded. This is exactly what my community needed. And so, Henry, with that, do you have anything innovative program-wise that you'd like to share with us?
Yeah, we have several initiatives that have gotten citywide notoriety. One is we have, when we built our new Miles Square Health Center and got federal funding for it, it was certainly a state-of-the-art academic community health center sitting in the Illinois Medical District. So that in and of itself, getting that off the ground and all the parties to deal with the land acquisition and university-based issues and funding for this was certainly a major accomplishment, many years in the making, and only made possible as the culmination of the grant through the Accountable Care Organization, or ACA, American Expansion of Healthcare. As part of our new site, we have an urgent care center that's open 365 days a year. It has been a phenomenal success. As you well know, urgent care centers are not, even when people, in Chicago and in many urban areas, you have these docs in a box, and you have Walgreens and CVS, these pharmacies that are opening these small satellite clinics. Well, the truth of the matter is that while they open these clinics, at least in the state of Chicago, they don't welcome our public aid and uninsured patients. So consequently, our city of Chicago, we're the first in the city of Chicago and the Chicagoland area to provide urgent care to this population, to all payers for that matter. What I was most surprised by is that we have a very large commercial business along with our public aid business, and our urgent care business is busy every day. It just boomed. As a result of that, we're looking at implementing immediate care, which is a little different than urgent care. At some of our practices, I'd like to establish immediate care in each of our regional sites. We are launching our first immediate care site in the first quarter of FY16 before the end of October of this fiscal year. Immediate care is slightly different than urgent care. Urgent care provides a much fuller array of services. We have radiology there. We're able to do images, the whole 9 yards. So it's really a very comprehensive urgent care center. So we're very, very proud of that. The second innovation we're proud of, and one in which we're ongoing learning how to add technology to our practice. The use of technology is a real interest of mine, learning how to, and by that we're using telehealth, telepsychiatry, telemedicine, and we're doing more than we have telemedicine. That's funded through one of our foundations. The third is we are integrating more primary specialty care. We are linking and convincing our university partners to provide specialists in the community. So we're looking at adding to our scope of services cardiology services, endocrinology services to help provide better care to our community and in the communities we serve, not just at our main site here at Miles Square, but deep into those communities, so to make that service much more available to them. So we're proud of all three of those initiatives.
That's really, really wonderful. Henry, can you tell us more about specifically the telehealth piece? And you said that you were able to get a foundation interested in supporting that. Can you tell us more about how you worked with that funder in order to, and how long it took you to sort of from the beginning of the meal till the dessert, how long that process was?
It took us about a good year to get all the pieces together to compose a good document that sort of provides a vision for telehealth. Now, part of the telehealth program, we've learned a lot about it, especially we started off with psychiatry, which was a very complicated model to begin with. Number one, because of the challenges in maintaining psychiatry, and our psychiatrists in our practice was an ebb and flow in that staying on board. So we've expanded that service line to now we're looking at providing telemedicine services, so we can provide more of an expanded experience to more of our school-based clinics, which have challenges getting clinics in them. So we're creating virtual clinics tied to our actual clinics so that more of the CPS schools can have access to primary care. That's something we're starting this year. We have an evaluation part with it as well. But we've been at this for 3 years, struggling, learning to build, learning what works, learning what does not work as we look at adding technology as part of our learning. We are this year looking at a piece where not only we're providing the telemedicine, but the educational component we like to provide. There's a project called Project ECHO throughout the United States where we're looking at where we can do learning experiences where our providers can get consultation with specialists through telemedicine, something we're looking at launching this year.
That's wonderful. Has the same foundation been involved in all of the projects, or
yes,
were they
yes,
just sort of
the very same foundation?
That's really great. And
yeah.
So every year would you go back to them and say, hey, we did a great job on this, we want to expand it, or how did that sort of?
It's been really saying, we've been very good stewards of the money, and when we're saying, we didn't spend this, we like to carry it over, or we like to request more money, they've been very, very supportive of us in that regard.
That's really great. Thank you so much for sharing that.
Sure.
Phil, when you think about innovation at Clinica Vista, do you have a couple of projects that you guys are pretty proud of?
I would say that probably our biggest achievement so far has been our teaching health centers in Fresno and in Kern. We are really dealing with a huge primary care provider shortage, and it's just been becoming more and more challenging for us to recruit and retain our provider staff. And so here in Kern County in particular, our county hospital was planning to end their family practice residency program. And we worked with the hospital and our county board of supervisors to essentially help guarantee funding for this project at least for another 5 years, even if the federal funding fell by the wayside. And it's still costing the county about $1 million less a year to run under our organization than it was through the county hospital.
Wow.
So we are getting ready to bring in our second year, or our second class of 6 here in Kern and 4 in Fresno. Fresno was about a year ahead, and that's actually funded through another entity that I'm not as familiar with, but we're getting ready to bring in our 3rd class up in Fresno. So once we're fully implemented, and we'll be graduating 10 new residents a year starting in June or July of 2017. So that's probably one of our biggest accomplishments. We are planning.
Yep, keep going. I'm sorry.
So that's our teaching health centers. We are looking at, we're not calling it urgent care, but it is going to be an expanded hours clinic that's being funded by one of the managed care plans that we work with, and trying to reduce or defer people from the emergency departments. And that will be opening up hopefully by August, and we'll be running that 6 days a week from like 2 p.m. to 10 p.m. to start with. Again, because of one of the challenges we have, again, is really moving a provider into that position who isn't already busy at another site. So that may delay that project a little bit, but hopefully we'll have that available for folks after hours. We do have a number of health centers open until 7 p.m. Monday through Saturday. We have no health center currently open on Sundays, but our CEO believes that someday we'll probably be open 7 days a week, and maybe even have this expanded hours facility open, 7 days a week as well. But we're just trying to get that off the ground right now. And then hopefully we'll be opening up this health center in a public housing facility later this summer as well. So those are kind of the big areas that we're looking at right now that are either in the works or we've been able to get going.
That's really wonderful. Thank you. Do you know more about the conversations with the managed care provider in order to expand access in the expanded care site?
Well, this is our local initiative, so it's a nonprofit. It's not a for-profit managed care entity. So they have been accumulating quite a large reserve, which our CEO and others have been really saying, look, you need to reinvest in, especially into the safety net providers. We're the folks of last resort. So our county hospital, along with the 2 FQHCs that are here in Kern County, receives a substantial amount of funds to help support these types of services to, again, divert folks from the ER or emergency departments. So it was really approaching their board and looking at their obscene reserves that are like 5 or more times more than what is required by law to hold, and convince the board that this is really important to invest in us. They are also helping support some of the private providers, but the bulk of funds went to the safety net providers.
Great, great. So when we think about sustainability, that's always one of the challenges when you're talking about grant funding. Do you have any approaches that you think you could recommend to folks that have worked really well when you're talking about how to sustain a program and funding? What do you think, Bill?
Well, that's the $64 question. I don't know if I have a really good solution other than that the only way to sustain something pretty much for the foreseeable future is to get it institutionalized somehow or make it a Medicaid reimbursable service. Grants, whether they're foundations or from federal, state, or local agencies, rarely go on forever. We do have some local grants through a tobacco tax, Proposition 10 tobacco tax, that have now been funded for about 15 years, which is really, really a long time for a grant to be going. However, that funding source is dwindling, so we're now looking at other avenues. And what Juan had mentioned earlier about this Health Homes State Plan Amendment project, it's part of our state 11 to 15 waiver, and I know it's part. I think it's the section 2703 or 2708 of the ACA. Is a way of, again, of being able to provide a sustainable funding source when we can demonstrate by providing more care coordination and linkages to social support services that we're able to reduce the cost of care for people with chronic disease and severe, mental health and substance abuse issues. So I think part of that is, to sell that, again, that's going to be a big selling point to our state and the feds, is to be able to demonstrate that by having these types of programs in place, we're able to save money in the long term.
Great, thank you. Henry, what are your thoughts on sustainability?
I think Bill was spot on in terms of the more you provide service that are eventually going to be reimbursable, the better off I think an institution will be. I think, as you described, grants are not forever. They do have a finite period of time. But if you look at your strategy of grants being used to launch and defer the upfront cost of getting a program implemented is probably your best strategy, knowing that you're going to be reliant upon your operating revenue to support it going forward. The second piece I'd like to also caution is that, you have to do a benefit analysis in terms of grants. The administrative costs sometimes associated with a grant can be overwhelming. So all money is not necessarily good money, so there needs to be that level of evaluation to ensure that your staff's time can be used where it's going to get the greatest return for the organization. Lastly, I think as we look at this, I think the main emphasis has to be placed on sustainability of the operations, ensuring that you're being highly strategic and thoughtful about how you operate in this new ever-changing healthcare environment where reimbursement is changing and things are being cut left and right, and how do you. So, you have to stay focused on your core business, your core principal business, in order not to lose sight of things.
Great. Thank you so much. So as we move toward the end of our call, is there any advice that you would give another health center in trying to figure out ways to identify an alternative source of funding? Henry, you want to start us out on that?
Sure. Every state's different, so I would take a good hard look at what are your third-party reimbursement opportunities as your principal source of funding, and being able to squeeze as much money out of that, because that's really what pays the bill in terms of the following. One, if there are bonus dollars that you can tie into as a result of your managed care contracts, not being afraid of getting into managed care contracts, ensuring that you protect your prospective payment rate or your FQHC rate, but also leave opportunities for creative financing from bonuses and taking on a little risk, I think can bear our organization, can do well for organization in the long run. But I would really pay close attention on what the states are doing, what the feds are doing, what CMS is doing, and try to stay at or ahead of the curve with regards to that. Then secondly, aligning your operations so that your operations ensure that you're able to get as much out of these programs as possible, meaning the funding. You can get the funding and get the grants, but if you can't bill it properly and do follow-up properly, you leave a lot of money on the table. So you need to ensure you've got the staffing all the time to sort of look at ensuring that which you put into a contract you're getting money for, and that you're able to ensure that you're getting the money that's due to you.
Bill, what do you think? Any advice you would give another health center?
Well, I probably would give them very similar to advice of what Henry was sharing. Is definitely want to look at your core funding to be a reimbursable funding stream. I know that we are working at we have a new contract with our other managed care plan that is going to be a capitation agreement versus our PPS rate. And so I think we're looking at new and innovative ways of getting reimbursed for the services that we provide, and again, looking at those incentive dollars that we can get by showing that our populations are getting healthy and they're getting the proper assessments and screenings, and that they are staying out of the emergency departments and out of the hospital. So, from our organization, I think we have really diversified into a lot of different enabling services that allow us to serve a lot of different special populations. So that's kind of how we have grown. I think each agency has to kind of look at what their core mission is, and to really have that as a guiding principle of where they're going to be looking for funding. But we have really focused on a lot of different special populations. We've been in the HIV AIDS service arena now for over 20 years. We weren't there right up front, but we did come in the early 90s when we felt that the epidemic had really reached our area, and so we've been very successful in that area. But it's a lot of hard work. I know that all of us think about this constantly, and really just trying to get a sustainable funding source for a program is really the ideal.
Well, great. I want to, do you have, before we close, was there anything else that you wanted to share or you think would be helpful to share? Or we sort of covered everything? I'm thinking we sort of have, but are there any last things?
This is Juan. You know, I would just say that if there's newer or organizations that maybe are beginning to access new funding, or whether it's state funds or federal grant opportunities, you know, that, you know, I think Henry mentioned this, to be good stewards of the money, you know, be as transparent as possible, be responsive, develop very good communication lines with your project officers or your grants management departments, you know, be responsive to their reporting needs. I mean, they have bosses as well. If you make their job easier, they're going to make your job easier, and it's going to make the money flow smoother. And I've noticed that, you know, over the decade that I've been supervising HIV programs, you know, I rarely, you know, I pick up the phone, I use email to share information, and when we're having challenges, and then times when we do have audits, we have good working relationships with the folks. So it doesn't become an adversarial, it becomes more of a partnership. So I would just put that as advice to someone, and I think that's been successful for us.
Absolutely. Thank you, Juan, for bringing that up, because it really does come down to relationships. The ability to work collaboratively with a funder and develop an idea and develop a trusting relationship so they know that you are good stewards of their money, as well as talking with them about programmatic expansions. And, you know, oftentimes they say money begets money. You know, it's easier when you're a successful, healthy program who's doing good work to continue to get support from other funders. So I do want to take time to thank you all for participating in today's webinar. Henry, thank you so much. The people in Miles Square are lucky to have you, and Bill, Juan, and Margarita, thank you guys so much. Clinical Vista is a wonderful, wonderful health center, so I wish you guys wonderful luck, and thank you all for joining us today on the webinar.